Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, you have.
Thank you, Maren. It's a pleasure to be with you all for this session. We're here as our concluding session on the forum on preserving secure and sustainable access to healthcare data. This session will discuss the analytics to increase revenue streams and opportunity. It was organized by Kenley Money from ACHI. And again, we want to mention and thank our sponsor, IBM Watson Health, who has sponsored the entire forum, and we're appreciative of that. So I'm going to go ahead and welcome Kenley to the stage. Kenley, how are you today?
I'm well. I didn't realize I was the last one on Friday, but yeah. Yay.
Yay.
So thank you. Mm-hmm.
All right. Well, why don't you go ahead and take us from here?
All right. Good afternoon, everyone. Again, my name is Kenley Money. I'm with the Arkansas Center for Health Improvement, or ACHI, ACHI for short. And I'm the director of the Arkansas Payer Claims Database, which is part or the foundation of the Arkansas Healthcare Transparency Initiative. And I have the pleasure today of kicking off the last session that stands between us and the weekend, but an exciting session it will be, analytics to increase revenue streams and opportunity. In today's session, we'll have 3 videos, and each presenter will be online and available for questions at the end of their video. As we've done before, audience members should put their questions in the chat. As moderator, I'll read the questions to the speakers during the Q&A time after each session, and then again at the end, there will be time with us all. And with any luck, we'll have much time for the additional questions at the end. So without any further ado, I'm going to introduce our first speakers. Allow me to introduce Erica Plante and Kelsi West, whose topic is Planning for Project ECHO in New Hampshire, a multi-phased approach using claims analysis with survey and stakeholder research. Erica is a senior scientific analyst with UNH. Kelsi is a project director with UNH, Institute for Health Policy and Practice. And I will let them talk about their project and their roles. Kelsi and Erica.
Hello, everyone. Thank you for joining us today. My name is Erica Plante, and I'm a senior scientific analyst at the Institute for Health Policy and Practice, also known as IHPP, at the University of New Hampshire. I'm joined today by Kelsi West, project director for the Citizens Health Initiative at IHPP. Both presenters today have no conflicts of interest to disclose. Today we'll be talking about planning for Project ECHO, but before we do that, I would like to briefly describe IHPP. IHPP has 5 primary focal areas: health law and policy, health analytics and informatics, delivery system and payment reform, long-term care and aging, and public health and promotion. Project ECHO, which Kelsi will describe more in detail shortly, generally operates under the delivery system and payment reform focal area. But like many projects at IHPP, it benefits from an exchange of data and knowledge among all the focal areas. Kelsi will now describe Project ECHO and planning for Project ECHO in more detail.
Thank you, Erica. So now that you know where Project ECHO sits within the university, we're going to describe what Project ECHO is. So a lot of people are starting to hear this terminology more frequently. And for those that do not know, Project ECHO is a not-for-profit movement that grew out of the University of New Mexico, and it stands for Extension for Community Healthcare Outcomes. It was founded in 2003 by Dr. Sanjeev Arora, who is a liver specialist. In 2003, Dr. Arora was frustrated with his growing 8-month wait list for patients with liver disease at his clinic in New Mexico. He knew that if he could share his expertise in treating hepatitis C and other liver diseases with primary care practices in rural areas of New Mexico, the providers would be able to treat their patients in the rural setting. Sometimes patients were traveling hours for their appointments. So he and his colleagues developed the Project ECHO model and began utilizing it in New Mexico to share knowledge and expertise in treating hepatitis C. Within a year of implementing the program, his clinic waitlist went from 8 months to 2 weeks. Since 2003, ECHO has expanded nationally and globally and is being utilized by all types of healthcare professionals to cover a number of topics. Erica, if you could please go to the next slide. So our research sought to understand the needs of our communities and how Project ECHO can fit those needs. Our research was funded by a private foundation, and on the slide you can see all the people who contributed to the research. Our report, entitled Planning for Project ECHO in New Hampshire, the New Hampshire Project ECHO Planning for Implementation and Business Sustainability Project Summary Report, was published in the spring of 2020. As a note, this is pre-COVID-19 pandemic. If you go to the next slide, Erica. The project itself was a multi-part study that included a stakeholder survey, key informant interviews, all payer claims data analysis, business and sustainability planning, and evaluation planning. For purposes of this presentation, we are going to focus on the all payer claims data analysis. Erica, if you go to the next slide, we're going to talk about the project design, which included 5 key steps that looked at identifying the needs for the ECHO model in New Hampshire, determining the prevalence and volume of clinical condition issues identified by providers, then considering the current care and narrowing that list by focusing on current opportunities for ECHO to impact gaps in access and cost, exploring the impact areas by population and payer, and lastly, identifying key partners for implementing and sustaining Project ECHO programs. Steps 2, 3, and 4 utilized all payer claims data analysis, and Erica is now going to discuss some of the results from the project through the use of all payer claims data analysis.
Thank you, Kelsi. The results from the surveys provided us with a list of barriers for provider certification and key issues affecting a majority of their patients. We compared the list of key issues to the results from administrative claims analysis to not only corroborate the survey results, but also find other possible unseen key issues that were appropriate for future Project ECHOs. The claims data analysis found high administrative prevalence in the behavioral health conditions such as depression and anxiety, as well as joint degeneration. We also found that some patients were traveling great distances for treatment for substance use disorders, and that those with medical conditions such as COPD and asthma had longer periods of time between diagnosis and a visit with a specialist. Before I get into the data, I'd like to give some quick notes on it. IHPP has data use agreements in place to provide our team access to New Hampshire's commercial, Medicaid, MCO, and Medicare insurance claims and enrollment data. We also utilize the Optum Symmetry Grouper software that categorizes claims data into chronic or acute episode conditions. For this project, we focus primarily on chronic conditions. At the time of analysis, we only had access to New Hampshire Medicaid's MCO administrative data. To find rates of utilization for each condition, we produce what we call administrative prevalence, which looks at those who have the condition within an insured population. You may have noticed that we have produced separate results for commercial, Medicaid, MCO, and Medicare. This is because these populations by nature are demographically different, but also could have some overlap. Therefore, it is inappropriate to combine them. Nonetheless, you will see that there are several conditions that rise to the top for each population. For example, depression, hypertension, and obesity. Anxiety, diabetes, back joint degeneration, and other drug dependence were in the top 10 for at least 2 of the insured populations. The rates of back joint degeneration caught our attention as it may inform the topic of pain management, which was also in the surveys. Also, other drug dependence was interesting as we expected to see more specific dependent types, such as opioid or alcohol. We believe this represents the complexity of substance use disorders, as well as the challenge for coding for them in the clinical setting. We also provide the data behind the graphs. This slide is showing the top 10 conditions by percentage of total cost. What does that mean? For our analytic periods, we calculated the total medical cost for members with an indication of these chronic conditions, and then calculated how much of their total medical cost was spent for procedures related to this condition. It should be noted that at the time of our analysis, we focused on medical claims only and did not include pharmacy claims, which could have a significant impact on total costs. For the commercial population, we found that joint degeneration was contributing to a high percentage of members' total costs. But also notable for both the commercial and Medicaid populations, mental health conditions were contributing highly to overall member costs. And here is the underlying data. As Kelsi noted earlier, Project ECHO was created to expand access in rural areas, thus hopefully mitigating time and distance to care. For analysis on specialty care, we focused on the portion of the populations that had an administrative indication of a new case of a condition. We selected 10 specific conditions of interest to analyze time and distance to first treatment for that condition. This analysis was relatively exploratory to see if we could use administrative data to understand the timeline from initial diagnosis to specialized treatment. This slide shows the results of analysis on distance to first indication of specialty treatment. As you can see, we found that individuals with substance use disorders such as opioid dependence or cocaine dependence often had a median travel distance near or over 10 miles. And the underlying data. When we analyzed time to specialty care, we found that COPD, asthma, and diabetes had the longest times between initial diagnosis and their first specialty care treatment. It should be noted that this analysis does not adjust for severity, and again, does not include pharmacy claims. And once again, the underlying data. Once analysis was complete, the team was able to pair this information with findings from the surveys to formulate a plan for ECHO opportunities. This slide illustrates how results from the surveys and data analysis were synthesized into opportunity categories for future ECHOs, including adult behavioral health, care for older adults, and quality improvement. These key issues came to the top, but as we all know, COVID-19 changed a lot of plans. So in the spring of 2020, UNH Project ECHO launched telehealth for special populations during COVID-19 and beyond as a rapid response to the COVID-19 pandemic.
We want to thank you for listening to our presentation. We have provided both of our emails on this slide if you would like to contact us. We have also provided our link to the Project ECHO website at UNH, where you can see our current running ECHOs and our past projects. Thank you all and have a great rest of your day.
Thank you. I'll give everyone an opportunity to enter questions in the chat. That was very, very interesting. So without seeing no questions in the chat, that is not your only chance. Let's move on to our next set of speakers. And those of you who have questions can ask them at the end. All right, so our second presentation, Norm, if you wouldn't mind switching. Allow me to introduce Kate O'Neill and Jessica Mendizabal. All right, they're coming, I promise.
Hello, I'm Kate O'Neill, and I'm presenting today with my colleague Jessica Mendizabal, and we are staff at Vermont's Green Mountain Care Board. Our presentation focuses on the data enhancements we have underway and planned for the near future. Vermont's Green Mountain Care Board is an independent 5-member board with regulatory duties that include Vermont's hospital budgets, health insurance premium rates, certificates of need, ACO certification, and a whole variety of other duties related to data, analytics, and evaluation. And our data team here works to provide timely information to support the board as well as the public. Now, the Green Mountain Care Board manages and maintains several data assets, and they include Vermont's all-payer claims database, which we refer to as VCures, and Vermont's hospital discharge data system, which we refer to as VUDS. And here are some examples of projects conducted using VCures and VUDS. Our Department of Health here in Vermont published findings on mental health related emergency department claims for Vermont's children, and RTI International published a study they conducted in Vermont on the risks and adverse events associated with the rate of tapering and discontinuation of opioid medication. Some examples of projects currently underway but not yet published include UVM College of Medicine, which is studying the impact of opioid prescribing policy on hospital utilization for opioid overdose, and our Vermont Department of Health is studying the health impacts of extreme heat in Vermont. And we do have a long history of approved data release to state and non-state research partners, but we also aim to expand access to our healthcare data and to improve the usability of those resources. And so we're doing this in 4 primary ways: strategies for data linkage and integration, enhanced data validation efforts, developing data files tailored toward areas of analytic interest, and publishing interactive reports and dashboards for public use. On data linkage and integration, in 2020, our Data Governance Council voted to approve a data linkage policy to support meaningful and more robust use of our data resources. The stewardship concerns that they discussed when building this policy were about ownership of the linked data set, protections of the linked data set, who approves the linkage and how, and the criteria that would be used to determine eligibility. So on this slide, we have some examples of projects for which data linkage was approved, including for UVM College of Medicine to link cancer registry data with VCures claims data, as well as linking mortality data. Also, Vermont's Blueprint for Health has linked VCures with the Vermont Clinical Registry for enhanced reporting to support their programs. We are also exploring ways to make our data and information more meaningful to broader audiences through integration with electronic health records and vital statistics. Also, we're collaborating with larger statewide integration and collaborative services efforts that are being pursued through Vermont's Health Information Exchange. On enhanced data validation, our data team, along with partners, are in the process of validating our claims database to see how it compares with providers' and payers' financial information. And this is going to help us with further analyses for improved validation, and will support our production of an upcoming interactive report on reimbursement variation in Vermont, and that's scheduled to be published in early 2022. Now, our overall objectives with this enhanced validation work are to validate payer financial information with data that's consolidated into VCures, and to produce ongoing mechanisms for payers to audit post-consolidated data in VCures. And then we also want to be able to determine how well payer financial records match those that are maintained by providers, all in aggregate, and then to determine how well the financial records in our APCD match those maintained by providers. So that's a very brief overview of our first 2 strategies for improved and expanded access and ease of use of our data resources. And now I'm going to turn it over to Jess to describe our other strategies.
Thanks, Kate. So as Kate mentioned, we've been working toward developing public use and analysis-ready data files to meet a variety of current and potential user needs. In early 2020, we contracted with the Vermont Program for Quality in Healthcare to complete the research for this work. The first phase involved identifying informational gaps in previous work, as well as potential use cases and user populations. In phase 2, they conducted stakeholder interviews and completed a review of other states' data products to give a better sense of what might be possible in a state like Vermont. And some common themes that came out of those stakeholder interviews included the need to analyze cost, quality, and utilization out of the data set, the desire to link supplemental data sources such as vital statistics, and that potential users may be lacking in technical expertise to navigate the data sets as they are currently provided. And so I've included a link here to the detailed report for anyone that would like more detailed information on that. So we discussed the recommendations from the report with our Data Governance Council this summer and developed the matrix that you see here, which categorizes the recommendations and helped us prioritize where we wanted to go next. The highlighted recommendations are essential to complete in order to produce useful files that are ready for analysis. And so we'll be focusing on those over the next few years. And as Kate mentioned, some of those are already underway. We've also been working across our divisions at Green Mountain Care Board to develop a more streamlined way to access reports. And these are some images taken directly from our website where we tried to organize the reports and data briefs in a way that was more easily accessible to the public. We publish most of our interactive reports using a Tableau software and recently worked with our IT department to embed them directly into our web pages. And this has helped us establish more of a brand and also helped users access these reports more readily and be able to navigate between reports without actually having to leave our website. And as this slide states, all of this is still a work in progress. So here's an example of one of our interactive reports that's available through our website. And this looks at all payer total cost of care, and it uses VCure's data. You can see there's different tabs at the top there, which would allow a user to navigate between a few different dashboards, so a few different looks. And really the goal here is to make this information accessible to members of the public, average folks who don't have the maybe technical expertise to navigate the data in a more raw format. This is just another example of where we provide reports using VCures and BUDS. This image is of our patient migration report, and it is showing our results at a subgeography of a hospital service area. Patient migration looks at where patients are receiving their care and the associated expenditures. Patient origin shows where patients are traveling from to receive their care, and it's using our BUDS data. So just one last example of an interactive report that we have. This report is looking at healthcare access, and this particular dashboard is using socioeconomic metrics to help us understand healthcare access across the state and what might be affecting Vermonters' access to care. And so again, we're just trying to take into account all these different data sources and put them in one place on our website where folks can access the information and try to understand the bigger picture of what's happening with healthcare in Vermont. We just wanted to link to our data and analytics page where folks can come here and explore our different reports and understand a little bit more about what Green Mountain Care Board does. So we would invite anybody to take a look and certainly let us know if you have any questions or feedback. And with that, if there's any additional questions about this presentation, we're happy to answer those when the time comes. Thanks so much.
Thank you so much. Very good. Were there, I don't see any questions in the chat yet. Let's give everyone a moment to compile and type. And if not, we'll don't worry, I have plenty of questions at the end, so we'll fill the time most certainly. So
Be here.
All right. Well, then why don't we move to our next group? I want to introduce Dr. Mitesh Rao and Dana Richardson. Their topic is putting health data to work to support healthcare Innovations. And without any further ado, I'll let them introduce themselves as part of their presentation. Welcome.
Hello, I'm Dana Richardson. I'm the CEO of the Wisconsin Health Information Organization, and I want to welcome you this afternoon to our presentation on putting health data to work for innovation.
And I'm Dr. Mitesh, founder and CEO of OMNY Health, and we look forward to talking to you today about our partnership as well as opportunities for all of you to be able to join. We're going to set the stage really quickly with a little bit of background here. So first and foremost, data sits locked in healthcare across very siloed systems. And even though the industry does strive to share that data, it's very difficult to do so at scale. Pairing up with this, of course, is the fact that data has really started to drive a lot of the future in healthcare. COVID has only highlighted the fact that there's so much opportunity for cross-industry collaboration, whether it is powerful drug discovery, device development, or just improving the general quality of healthcare provision. Finally, this market is quite large. The real-world data market generates $250 billion in revenue a year, and it's very difficult for most organizations that actually generate that data to tap into that market share. The key here is a centralized and linked data layer that normalizes, reorganizes, and structures the data and helps build those partnerships at scale.
Through our partnership, OMNY Health and WHIO aim to normalize data and to create a real-world pipeline of data that powers life-changing innovation. Over the past few years, the WHIO has experienced increased use of our data by researchers in Wisconsin, but it's difficult for us to connect with researchers outside of our state. In addition to that, we've talked to several life science companies who are interested in a multi-state representative sample of claims data. The OMNY partnership opens the way for expanded use of our data as part of a national network through their marketing portal and data preparation. The Wisconsin Health Information Organization is Wisconsin's all-payer claims database. Our vision is better health, healthcare, and healthcare value gained from objective information. Our goal is to create more data, not just claims data, but all types of data. And we produce data files, standard reports, custom data extracts, and custom reports. Our standard database has about 4.9 million insured lives in it. These lives are based on the claims that are submitted to us from commercial, self-funded Medicaid and Medicare Advantage plans. For this partnership, we'll provide our standard integrated data file, which is a de-identified data file, but for the purpose of this, for research, it is considered a limited data set. The WHIO's data set also includes a non-intelligent key, which we call the WHIO ID, that can be used to link different data files together for longitudinal analysis.
OMNY Health is the first partner-driven data collaboration, and it's a platform designed for transparency and trust. We build partnerships with real-world data teams and health outcomes researchers all over the country, helping them get ready access to prepackaged and curated data files across hundreds of therapeutic areas. These teams have immediate access to powerful data partnerships across a network of nearly 13 million lives. These data points come from our partnerships, encompassing nonprofit and for-profit providers, national cancer institutes, children's hospitals, and single and multi-state specialty groups. And through this partnership, we aim to leverage the data to improve care outcomes, expand market outreach, reduce administrative costs, and increase revenue. We work together in a stepwise process. First and foremost, begins with the data, where data is transferred to OMNY securely. Once it hits our shores, it is optimized, cleaned, reorganized, and integrated into a common data model. From there, the data specs go back to our partner organization where they are reviewed and approved. Once the approval is in place, OMNY goes to work creating data products that are tailored to meet the specific needs of research groups across our life sciences customers. We share this de-identified data with these life sciences companies in exchange for a usage fee, the majority of which goes back to our data partners like WHIO. Finally, OMNY's team focuses on scaling partnerships, aiming to expand data partnerships that meet the ever-evolving needs of life sciences companies all over the country. This leads to two things. One, a net patient benefit of an opportunity for reinvestment in patient care. And second, enhanced industry knowledge for care innovation.
When the WHIO was considering this partnership, there were several things that were very important to us. First and foremost, it was important to us what were the types of organizations that would have access to the data. And for this partnership, it's limited to life science partners. In addition to that, we need to maintain compliance with all patient privacy and security regulations, and to protect the data from being resold or redistributed to other organizations. Finally, it was important to us that the data be used to enhance knowledge globally and that not to be used for direct patient or provider marketing or campaigning.
Omni Health platform is built for control and data transparency for all of our data partners. First and foremost, they can review and have to approve all data sets as they are created from the derivative products that are created from all of our data dictionaries. Two, they have immediate access to that clean structured data by therapeutic area or product. These data sets can be downloaded, leveraged for internal analytics teams and research initiatives. And three, the platform is designed to allow all of our data partners to track the value generated by product type and disease area. They're able to monitor the utilization of their data and understand the value that it generates.
Thank you for spending some time with us today to learn about the Omni Health platform and the partnership with the Wisconsin Health Information Organization. We invite you to consider joining our partnership and create an even larger network of data to improve the health and the healthcare delivery system for all in the United States. Have a great day.
Thank you.
Thank you so much. Thank you. I'm going to open it up to questions now, and there's a question in the chat for you. Adrian Texador asks, can you please say more regarding the key that allows different data sets to be connected?
Yes, absolutely. So on our side of the platform, Omni is undifferentiated for tokenization. So we will create keys and tokens using many of the tokenization standards. There are many companies out there, Sonoma, Datavant. There's not really a key industry leader per se. So we maintain that flexibility to ensure that all of our data partners can integrate their data into any data opportunity. But we generate those keys on our side for most of our data partners. Some of our data partners generate the keys on their own side. It all depends on the organization. And then that allows that de-identified data to be linked to other data sets, but also for us to have call continuity in the data, for us to be able to follow along, even though patients are de-identified, and create patient journeys and understand the context of disease progression, which is really valuable in the health economics outcomes research space.
In this partnership, did Omni Health generate the key, or was it Wisconsin?
No, we won't be generating the key on our side.
Okay.
Yes.
Okay.
Yeah, I would just add that we also have a key that we use within our own data set. We call it the WHIO ID, and I think I mentioned that in the presentation. Yeah. We use an enterprise master person index to do that. So as all of our data comes in, our enrollment files are run through the EMPI, and the EMPI looks to see, is this person already have a key? If so, it uses that key for all future data. If they don't have one, there's a key generated. And that actually allows us to create longitudinal data files even without linking. But it is another way that you can kind of generate that linking key, and we use it in our data structure as a primary key.
Is this key based on PII in your data system?
It is. We run the PHI through the EMPI software.
Okay.
And then we scope out all the identifiable data.
Yeah, when we generate on our side, we do the same thing.
Yeah.
Run some of the core PHI elements through, create the token, and then we delete.
Okay.
We keep only the token.
I ask with some envy because our APCD does not have PII. So we have to go the hard way around. All right. Does anybody else in the audience have questions? If so, put them in the chat. And while you compile your questions and typing them in, I would like to bring everyone else on, all of our other speakers on. Oh, a question has arrived. How much do you charge for access fees? Who owns the data?
I'm going to assume that question is directed at me. Great question. So the market access fee is transparent and built on fair market value. So we establish that fair market value and allow it to have equality across the board. As far as ownership of the data, every organization that contributes data into the OMNY platform owns their own data. They maintain full visibility on it, full control, can deactivate the data, sunset it, if you will, at any time. That ownership and control is maintained on the data partner side. We believe it's your data, you should own it, to be able to leverage it and build relationships with it.
Okay. All right, well, I'm going to pose a question, and it will be to Dana and Mitesh. With this partnership that your organizations have, and under the auspices of our session title, Analytics to Increase Revenue Streams and Opportunity, what revenue stream or opportunity have you been able to achieve, or what is your plan? Do you have anything specific that you're working toward?
That's a great question. So WHIO and OMNY have just started this partnership piece. So we have not kicked off the data being available on the data platform, but we're really looking forward to that piece. And we're in process of sort of starting our partnership now.
Yeah, and I would just add that from my perspective, it does help us to expand our market reach. We're a very small staff, and so we don't have a lot of time to, talk to people. So we tend to work with organizations that contact us, but they have to know that we exist, right, and that the data is available and that type of thing. So I really see the expanded marketing that OMNY Health brings as a value add for us, and the lift in order to be able to provide them the data is relatively small. I don't want to say anything's without resources, but it's not a huge lift for us, and so consequently, it is a way for us to expand our revenue stream with a small investment.
Adrian has asked a second question. What is the level of linkage allowed by your program, Mitesh?
Can Adrian clarify that a little bit more? Just want to understand the context there.
Adrian, can you respond?
If not, happy to answer questions offline. Easy to connect with.
Okay. All right. Okay, well, my next question is to Erica and Kelsi. In your presentation, you described the example of a provider who was having issue with timely access. And that was a very compelling example. Was there any other incident that could serve as a trigger that you used as a trigger to help support the journey that you took with Project ECHO?
The analytic perspective, it's we were casting a wide net to see what was available, what was in the claims data in comparison to what was reported in the surveys. I think the surveys were quite interesting, and I highly recommend reading the paper because those were actually done in a separate process. So I'm not sure if Kelsi wants to speak to that more, but regarding the data, we actually just kind of cast the net out to see what rose to the top for what we call administrative prevalence, because it's not technically prevalence, but also in costs. So I think more our thoughts in the original development of the process of what was trying to see what we could see, what was there in the different populations. Kelsi, do you want to speak to the survey findings a little bit?
Yeah, the surveys went out to, it was a snowball survey. So it went out to a bunch of stakeholders that were in our networks, and then it got spread out to other people in their networks. And it was really to cast a net. It was a needs assessment. So it was to see what were the needs of New Hampshire for Project Echo. Our team had just been trained in the Project Echo model, which is what that story was about. And now we wanted to know, well, that's the needs of New Mexico. What's the needs of New Hampshire? And by looking at the data and what our stakeholders were saying, we were able to see what the needs of New Hampshire is for Project Echo.
Okay. Okay. Oh. For Kate and Jessica, I think I heard you talk about I'm reading my question. I believe I heard you say something about enabling the payers, or it's supposed that the payers could use this data, the ECHO data or the ECHO tool infrastructure for perhaps data quality or comparative analysis. Did I understand that correctly? That it's a potential use of it?
We're hoping that in the future, in our enhanced validation effort, that we would be able to engage payers in a post-consolidated manner to be able to understand the data in the all payer claims database, to see it and to be able to do a more ongoing comparison. So we're starting with this first effort, and then we hope to be able to have something more recurring in the future.
When you say post-consolidated and comparisons, do you envision that this data, that they could use this data for their business analytics? Or is it just a validation step to make certain they're delivering to you appropriately qualified data?
Yeah, that's a good question. I think that right now we are focused on validation. Okay. So we would work with our payers, though, to understand, the potential opportunities that would exist there, but we haven't gotten to that that place yet. I wanted to say, I don't know if Adrian's question was for us, but I can talk just very briefly about the level of linkage allowed by our program.
Okay.
If that was helpful.
Always interesting.
So we do allow data linkage with our data assets, but we do limit it to project specific and to a time-phased approach. So it's not we are also exploring opportunities for data integration, where we would have integrated data sets available for analytics at a variety of levels. But in terms of data linkage with, two data sets brought together for the purpose of research, our Data Governance Council said we need to limit that to specific projects, and for each time a research request needs to go through the approval process, and that is applicable to our state agencies, the University of Vermont, as well as any other non-state research entities.
Okay. Thank you. And I see Norm has asked Adrian for some clarity. Poor Adrian. As you build your Echo platform and solution, what have you given any thought to the types of website reports that you want to generate from it, that they can provide analytic information just the same as the APCD data?
I assume that was for us, Project Echo?
Yeah, I'm sorry, for Kate and Jessica, yeah.
Oh, for Kate and Jessica.
Let's start there, and then we'll go back to Erica and Kelsi. Website reporting as you design your platform. Mm-hmm.
Okay, so we're not working with the Echo platform.
Did I say Echo? My apologies for that.
I just wanted to,
my apologies. Okay, let's start with Kate and Jessica. Website reporting.
So what we've been working on over the last year and a half or so is developing these interactive reports through a Tableau software, and it is like a manual
upload into the data workbook. But the idea is that we're making it accessible for public users that wouldn't otherwise have access to that data. So are you asking about next steps with that?
I am. We yes, and specifically about what types of analytics, like Google Analytics, that you have on your website to track its use and identify areas of enhancement.
Sure, just usage overall. It's a great question, and it's something that we've been talking about, and we're not exactly tracking it in the best way right now. And so I think as we've been putting together this presentation, realizing that we do need to get some sort of baseline for usage and come up with a better way to track. I think the Tableau public site tracks the number of views, but it's not entirely helpful if we are continuously accessing that internally, as well as, if you spend enough time there on the dashboard and you click through the different tabs, all of those views get counted. And so really, my thought is just if anybody in this group or who's listening has a better way to do that, let us know.
Yeah, it's a good place to ask. Okay, so I'm going to ask the next question of each group. We'll begin with Erica and Kelsi, then Kate and Jessica, and then Dana and Mitesh. In your work in the project that you discussed today, what was your greatest challenge, and was there a surprise finding? We'll start with Erica and Kelsi.
So as you may or may not have been able to tell from one of the first few slides that we presented, it was actually a pretty complex project with many different players involved, from assessment to clinical to actual echo planning itself. So it actually became pretty complex pretty quickly, especially since we weren't doing a study on like a singular disease where we could find an advisor who knew clinical information about one singular disease. We had all the chronic episodes that were available to us in our group. So we did have a wonderful clinical advisor who helped us determine things like proper treatment and what is an accepted amount of time to treatment. But overall, it was a little bit overwhelming at times because we just had sheer huge volumes of data that came out of the analysis. So I feel like that was probably one of the biggest challenges for the whole group, that once we were done, what do you do with all this information? And how do you distill it down into meaningful results that we can work with? I'm going to ask Kelsi what she thought was one of the more surprising findings, because I'm biased as the analyst, so I got to look at the data all the time. So from her perspective, somebody who has a lot of expertise in echo, I was curious to know what she thought was the most surprising.
I don't know if it's surprising, but very interesting. I wasn't surprised to see it at the top, but joint degeneration was really high across all three payers. And that wasn't something that we originally thought we were setting out to look at. And then it just happened to appear, which is what we wanted, right? That's what we were looking for, was to see what rose to the top. So that was really interesting to see. And we actually have a chronic pain self-management echo happening now that we launched this month. So the data is now being used to inform our future planning. So that was the most interesting to me, I think.
Great. Kate and Jessica, same question.
Yeah, so we're trying to improve our data resources and the ease of use of those resources. And so the biggest challenge that we have, I feel like it's kind of twofold. One is we, balancing the support that we provide for the needs of our board and its regulatory responsibilities, and with all of the data that we have available to us, but to be able to you understand what their needs are when they have those needs, and to be able to be responsive to that. So there's that balance, and then the other balance, which is a big challenge for us, is the challenge of making our resources available with our small shop, so that it's usable by the public, by members of the public, when they don't have, a deep bench of analytic skills, and when they don't have the capabilities to host large amounts of data. And so we're trying to make our resources available in a way that's still meaningful, but also usable. And we find that it's a challenge to balance that, and it's a challenge to balance those needs with the needs of our board, and limiting what we do to their regulatory responsibilities.
That makes sense. Any surprises?
Well, I can't really think of anything that has surprised us along the way, but we're really expanding now. So we're doing a lot of background and research, and developing our resources in order to build that expansion out. So we may find down the road that we are surprised by some things that we couldn't anticipate.
Okay. And last but not least, Mitesh and Dana, same questions, challenges and surprises.
I will say that we are early in our process, so I would say stay tuned, but we're really looking forward to what we're going to be building together, and we look forward to being able to share the feedback as well as stories about the process.
Yeah, I would say from my perspective, the biggest challenge was actually in my mindset. And that is that WHIO has always been the one using the data. We do put out de-identified data sets, but we maintained a lot of control, I guess I would say, over our data. And in this partnership, one of the things I know that OMNY works with fully identifiable data. We weren't comfortable going there. So as I mentioned, we're starting with our standard integrated data set, which is a de-identified file. They've been really great about just meeting us where we're at, because we're not used to letting somebody else do something with our data. Not that we won't know what's going on, but it's a little awkward for us. I am actually kind of excited to see what they'll do that's more innovative than what we've been able to think about doing. And so I'm looking forward to learning from that. But letting go is never an easy thing, even when you have control.
Those are very wise words. I appreciate your saying that. All right. Well, we are 7 minutes from the end. Adrian has provided some additional clarity to the question. Are there data sets that are prohibited from linkage to APCD data? Connecticut state statute precludes linking APCD data with any data set. Curious to learn what's the extent of permissible linkages. I think that question's to everyone.
So I'll go ahead and answer the question, because we do some internal linking as well. For us, it's not as much about what data set you would be linking to, as it is about ensuring that the data is fully de-identified, and that we have that control. So that one of the the linking projects that we've done so far, we've done internally, such that what actually rolls out the door is always de-identified data. So it's a little different twist, because we don't have that specific prohibition in our statutes. Yeah.
The same is true for Vermont, I think, by and large.
In New Hampshire, linkage is not allowed unless directed by the state.
Good information. All right, last chance for the audience to submit questions through the chat. And if there are none, then Norm, I will give it back to you to close out.
Thank you, everyone. We do want to just call to your attention a couple of things. If you are interested in winning the prize, take a moment now just to go ahead and enter that code interactive, INTERACTIVE, in the game area. You just click on it. You can do that while we're watching here. But we also want to draw your attention to something that we're doing this year that's new in a virtual format. We have 4 spotlight sessions. That content is available on demand. You can go to the spotlight sessions and watch and see their presentations anytime that you want. But we've also asked them to be available a few times throughout the conference for you to meet with them and ask them questions. So the first of those is coming up here at the top of the hour. If you want to just pop over to spotlight sessions, those presenters, those researchers should be available. Just find them in their video rooms, and then you can have an opportunity to interact with them here in just actually in about 3 minutes. They should be there. We hope that you will do that. We hope that you will make the conference more interactive. I know virtual conferences tend to be sort of like watching television. People just view and then they take, but they don't give, if you will. And we're really hoping that we can change that mentality for this conference, that you engage in the sessions, that you find people that you want to talk to, that you interact with them, whether that's by video or by chat. This platform makes it so easy for you to set up a time to, if you want to talk to Kenley, to connect with Kenley and set up a time to video conference right in the platform. So you don't have to, give out your cell phone number or anything like that. You can just find each other in the platform and have those interactive moments that we would like to have at all of our conferences. And one final note, all of the sessions will be available for playback, typically within about a half an hour to an hour of when the session is over. Come back to this exact same spot. You can watch it again. You can tell your friends, come back here and see it again. And I'm just going to go ahead and bring everybody on stage one last time just so we can say thank you to everybody. Kenley, if you want to do the thank yous, let you do the honors.
Well, thank you all. Great speakers, great presentations. And I am glad that we were able to help ignite and kick off the NATO virtual conference. Happy Friday and see you next week.
Bye-bye, everyone.
Bye. Bye.